Welcome to EM Cases Rapid Reviews, where we review the take-home points from the EM Cases main episode podcasts so you can ace your exams and take stellar care of your patients.
Hi everyone, I'm Taryn from the EM Cases team, and this is a rapid review of episode 27 on drugs of abuse. This review is part 2 of the Drugs of Abuse podcast, and here we are going to delve into more specifics. First, we'll cover the approach to stimulant drugs of abuse, and then we will cover the approach to depressant drugs of abuse. Alright, let's start this off by talking about the more stimulating approach. Let's talk about stimulating drugs. Today, we're going to cover 2 main points. First, we'll cover the approach to the hot and crazy patient in the emergency department, and then we'll go over a few things on cocaine toxicity. Alright, so you're on your next shift and you have your toxicology, history, and physical exam from Rapid Review Part 1 down pat. You pick up your next chart and it reads something along the lines of the patient being agitated and combative. You also notice an elevated temperature. This sounds like it may be that hot and crazy differential that you've heard about before. Before you get too excited about the potential toxins at play, don't forget your full medical differential as well. We won't cover the details today, but don't forget to think about thyroid storm, encephalitis, pheochromocytoma, sepsis, and heat exhaustion or heat stroke. Okay, now for the fun stuff, the deadly toxicology cases. Different toxidromes can lead to different presentations of a hot and crazy patient. Let's dive into them now. First, sympathomimetic. This is the toxidrome caused by methamphetamines, bath salts, PCP, cocaine, and LSD. You can remember this toxidrome by remembering that everything goes up. They become tachycardic, hypertensive, hyperthermic, have dilated pupils, and increased reflexes, as well as diaphoresis. Next, let's talk about the anticholinergic toxidrome. This is caused by things like antihistamines, diphenhydramine, atropine or belladonna, and your TCAs. And in case you were wondering, yes, this is the mnemonic of blind as a bat, dry as a bone, red as a beet, mad as a hatter, and hot as a hare. You'll notice one of the only differences between this and the sympathomimetic toxidrome is the dry skin. ASA. ASA toxicity is aspirin toxicity. This may not be the first thing you think of, but it can cause very similar presentations. Patients may have cardiovascular instability, they'll be hyperventilating, sweating, and hyperthermic. They'll have flushed skin, abdominal pain, and now the key feature, they'll have tinnitus as well. Last but not least, I want to touch on serotonin toxicity and NMS. Serotonin toxicity, previously known as serotonin syndrome, occurs when there is a drug-drug interaction or a combination of 2 serotonergic substances. It can also be seen in severe overdoses of single serotonergic agents. These patients present with hyperthermia, agitation, increased reflexes, and often with a tremor. This sounds really similar to your sympathomimetic toxidrome, so your history of a serotonergic agent is key to this diagnosis. NMS stands for neuroleptic malignant syndrome. It is seen in the context of antipsychotic drug use, both typical and atypical agents. NMS patients will typically have muscle rigidity. They'll also be hyperthermic with altered mental status and also diaphoretic. While each of these toxidromes will have slightly different management, overall the management is supportive. Start with your ABCs, including intubation and paralysis if required. Next, move to cooling measures immediately, like we talked about in Part 1. Specifically, cooling measures need to be initiated right away for any temperature elevations. Passive cooling measures include evaporative misting, cold wet towels, ice packs to the axilla and groin. Active cooling includes cold saline through the IV, bladder irrigation, peritoneal irrigation, and thoracostomy irrigation. These patients usually die from hyperthermia, DIC, rhabdo, renal failure, or hyponatremia, so keep all of these things on your mind and look for them. Alright, we've covered an approach to the patient presenting hot and crazy. Now let's talk about cocaine toxicity. There are 3 main points I want to cover about cocaine toxicity today. The first is dysrhythmias. The second will be cocaine chest pain, And the third will be levamisole-induced vasculitis. Okay, first, cocaine dysrhythmias. Cocaine can cause a variety of dysrhythmias, most commonly sinus tachycardia or atrial fibrillation. Cocaine can also cause prolonged QT due to potassium channel blockade. This means these patients are at risk for torsades and VFib. If you are seeing ECG changes, consider using benzodiazepines to counteract the increased sympathetic outflow and prevent cardiovascular collapse. If you are seeing evidence of sodium channel blockade, which would manifest as a wide QRS, consider treating with 1 mg per kilogram of bicarb, repeating to narrow the QRS. If your patient presents with chest pain in a known cocaine toxicity case, obviously pay attention. But more importantly, always ask about cocaine use in your patients presenting with chest pain. You may be surprised, and you need to identify these patients because both groups are at risk for cardiac ischemia, pneumothorax, and aortic dissection. If the patient is a chronic cocaine user, they are also at risk for accelerated atherosclerosis. And with acute use, we worry about coronary vasospasm leading to ischemia. Follow your typical ACS care except treat any tachycardia with benzodiazepines. Avoid beta blockers acutely. Cocaine users are at risk for levamisole-induced vasculitis. Levamisole is a substance used worldwide to cut cocaine. In fact, about 70% of North American cocaine is cut with it. It is a livestock deworming agent and is toxic to the vessels in the body as necrotizing vasculitis. This picture here is a mild to moderate example. It can be much, much worse. Have a little Google search to see what I mean. The treatment is to stop cocaine, but also make sure you check a CBC. These patients can have a life-threatening neutropenia. Okay, so we've covered the more stimulating part of this rapid review, but now let's finish off by discussing some key points when it comes to the opposite, the depressant drugs of abuse. These drugs of abuse are a bit more simplified as they typically present with one toxidrome. These patients are hypotensive, bradycardic, have constricted pupils, often have apnea, and if really bad, present in a coma. If faced with a patient in this situation, consider the following differential. Organophosphates. These patients will have the low toxidrome, but will also have the sludge appearance. Lacrimation, salivation, bronchorrhea. They've got sludge coming from everywhere. Next, consider alcohol. Toxic alcohols like methanol, ethylene glycol, and isopropyl alcohol. VBGs and electrolytes to help calculate anion gaps and osmolar gaps will be helpful here. Also consider GHB, hydrocarbons, and other sources for a decreased LOC. Your non-toxicology differential, such as intracranial pathologies, sepsis, etc., are all still really important. Management of these patients often starts with a trial of small doses of naloxone, especially if the breathing is decreased. The goal with naloxone is to maintain normal ventilation, not maintain normal mental status. Use naloxone with your standard supportive care measures. Give 0.01 mg per kilogram in opioid patients or 0.005 mg per kilogram for patients with unknown opioid history. Increase the dose in a stepwise fashion. If there is a good response to the naloxone, give an hourly infusion. Give 2/3 of your effective dose as an hourly infusion. This is because naloxone has a shorter half-life than most opioids, especially with the new opioids around, such as fentanyl patches and Oxy-Neo. One more thing, in case you were worried that I forgot about the ever-important ECG, think again. Obtain an ECG in these patients as well and look for specific findings. Prolonged QTC can be seen with methadone and may be corrected by naloxone. If you are seeing ECG changes, the patient needs at least 24 hours admission because of the prolonged half-life of methadone. Heroin, on the other hand, is a shorter-acting opioid, and these patients can be discharged after 1 to 2 hours if their vital signs are normal and they are independently mobile. There you have it, folks. Today we covered the approach to stimulant drugs of abuse, specifically the approach to the hot and crazy patient, and then some pearls on cocaine toxicity. Then we covered approaching the depressant drugs of abuse, mostly opioids. For full references and written summaries of drugs of abuse, go to emergencymedicinecases.com. See you next time!